Hello, my name is Dave Shearer, and this is an introductory talk on ankle fractures. The learning objectives for this talk will be first to understand the determinants of ankle stability. Second, we'll talk about sort of the normal radiographic parameters that can be used to understand whether an ankle is stable or unstable. Then we'll discuss some common classification systems that can help us categorize these fractures. And lastly, I'll talk about surgical indications and fixation strategies. So the first key point in understanding stability is that the ankle is a highly constrained joint. It's a little bit like the hip, and then it has osseous constraints. And it's also a little bit like the knee, where it has important ligamentous constraints as well. The osseous constraints are the tibial plafond, the medial malleolus, and the lateral malleolus. The tibial plafond refers to the weight-bearing horizontal portion of the joint that does the predominant load bearing. And the malleoli refer to the medial and the lateral malleolus, which are shown here. We can conceptualize these osseous constraints using this very simple model. It's almost like an upside down U with both the lateral and medial malleolus acting as buttresses towards talar translation. The ligamentous structures include the lateral ligamentous complex, which is the ATFL, CFL, and PTFL. Medially, the deltoid ligament, and then, of course, the syndesmotic ligaments, which maintain the relationship between the fibula and tibia. Again, coming back to this sort of simplified model, we can think of the bones and ligaments working together, where the bones are essentially a buttress against translation and the ligaments are a restraint. For example, if the talus were to translate laterally, the fibula will act as a direct buttress against that lateral translation, while the deltoid ligament works in pair with it to tether and prevent that lateral subluxation. In contrast, if the talus were to prevent the talus from shifting medially, the medial malleolus acts as a buttress, and the lateral ligaments are acting as a ligamentous restraint. So what parameters can we look at on x-rays to understand if the ankle mortise is stable or unstable? Well, the first and arguably one of the most important images is the Mortise image, which is taken by internally rotating the foot 15 to 20 degrees, which brings the x-ray beam in line with the ankle joint, as you can see here. Will generally be the best, most important AP view. On this view, what we can see is, number one, the medial clear space, which is shown here. This is a really important parameter for understanding the relationship between the talus and the medial malleolus, and hence the integrity of the deltoid ligament. Normal is about 4 millimeters, but personally what I tend to use more is just simple joint symmetry by looking at how the medial clear space compares to both the superior and the lateral clear space. And in a normal ankle, those will all be symmetric. On the mortise, we also often look at fibular length, which can be disrupted by an unstable fracture. There are several different measures for this. One is shown here, which is the dime sign, which is a relationship between the distal tip of the fibula and the lateral process of the talus, shown here. When there's shortening of the fibula, this line, which is somewhat like a Shenton's line, is disrupted. Here you can see on this fracture after fixation, where you can imagine where this dime sign might lie. Now, in my personal experience, this is probably the least reliable measure of length, but nonetheless, for completeness sake, I've included it here. This is another measure of fibular length I actually find much more useful, which is the Shenton's line formed at the lateral shoulder of the talus between the fibula and the plafond. I've outlined it here in red. When there's shortening of the fibula, this relationship is often disrupted, as you see in the bottom right image. The third way you can assess fibular length is the talocrural angle, which is a measurement between the angle of the tibial plafond and a line drawn between the tip of the medial malleolus and the lateral malleolus. Because the fibula extends more distally than the medial malleolus, this will should form an angle of approximately 83 degrees. What about the lateral view? Well, the first and probably most important thing is just the overall congruence. The joint space should be equal across the full from anterior to posterior. If there's any anterior posterior subluxation, then these will become asymmetric. The second parameter that I'll often look at, which has more to do with syndesmotic injury, is the relationship between the tibia and the fibula, which can be measured by looking at how much of the posterior malleolus is showing behind the fibula, as shown here. In cases where it's anterior or posterior translated, this relationship will be disrupted. The AP image I put last for a reason, and that's that I think it's the least useful of the common ankle images. This is taken with the foot facing directly anterior, but is therefore not in line with the axis of the ankle joint, and hence you get this overlap between the tibia and the lateral ankle mortise, and a much less clear picture of the ankle joint, particularly laterally. There are some measurements that you can assess that more relate to integrity of the syndesmosis. The first is the tibiofibular clear space, which is the space between the tibia and the fibula, shown here, and then the tibiofibular overlap. Now you can imagine if there's a syndesmotic disruption and separation between the tibia and the fibula, the overlap will decrease and the clear space will increase. So it's a reciprocal relationship there. All of these parameters can vary from one patient to the next. And so if you truly want to restore anatomy, it's often helpful to assess these parameters compared to the other side. So those are the X-ray views. Now shifting to classification systems, the simplest system and easiest to remember for early learners is the Weber classification system. In the Weber system, it's just based on the level of the fibular fracture, where Weber A is below the level of the ankle joint, below the syndesmosis. Weber B is at the level of the ankle joint through the syndesmosis, and the level Weber C is above the syndesmosis. It's important to think how the talus is moving in these different patterns. In a Weber A, the talus is actually being driven medially, which is leading to a tension failure of the fibula. So it's essentially that if it's an isolated fibular fracture, Weber A, it's essentially equivalent to an ankle sprain. The Weber B fracture and Weber C fracture both, the talus is translating in a lateral direction, and the fibula is failing by a push-off or mechanism. And in these cases, the medial malleolus is what's failing in tension. In the Weber C fracture, again, the talus is translating laterally, but in this case, the energy is traveling up through the syndesmosis and then breaking the fibula at a higher level. You can imagine that for the talus to push on the fibula and break the fibula at this higher level, there's no way to do that without also disrupting the syndesmotic ligaments. So this is the most important feature of the Weber C fracture. The other common classification is the Lauge-Hansen system. I'm not going to go into a lot of depth on this system because I think it can be a bit confusing and monotonous to review in great depth. But I do think it's, I would encourage those that are interested in treating these injuries to try to learn this at a greater depth, because I do think if you can really understand the Lauge-Hansen system, your depth of understanding of ankle fractures in this, their treatment will be improved. So the idea behind the Lauge-Hansen classification, the way it was derived was using cadavers, and the cadaver's foot was placed in a position, either supination or pronation, and then a force was applied, which could be external rotation, abduction, or adduction, and this led to reproducible fracture patterns. The four Lauge-Hansen classifications are shown here. And it's worth noting that the most common by far is the supination external rotation variant, which accounts for about 90% of ankle fractures. Again, I don't want to belabor Lauge-Hansen, but I do think it's useful to understand how the Lauge-Hansen classification maps onto the Weber system. So the Weber A actually corresponds to the supination adduction injury. The Weber B corresponds to supination external rotation. Remember, this is the most common. And the Weber C corresponds to the two pronation injuries. There's really little that differentiates pronation external rotation and pronation abduction, except for often the more comminuted fibular fracture with the abduction variant. So here's a very typical example of a Weber A or supination adduction type injury. We often jokingly call this the SAD injury. And the reason for that is that, again, remember that the talus in this case this is the very exceptional case where the talus is going medially rather than laterally. This has really important implications for treatment for a couple of reasons. First, if you're doing a closed reduction, the reduction maneuvers are going to be opposite of the reduction maneuvers for the other injury patterns where the talus is going laterally. You would not want to apply a Quigley maneuver to this fracture, or you'll actually worsen the deformity. The second reason why that's important is because there's often impaction of the medial tibial plafond. This enters into the spectrum of tibial pilon or plafond fractures, which are more axial loading injuries involving injury to the weight-bearing articular surface of the ankle. So you must scrutinize this area very closely anytime you see this pattern to look for any articular impaction, and it should be addressed at the time of surgical treatment. The Weber B fracture, again, is equivalent to the supination external rotation injury. These are generally associated with this very typical Weber B ankle fracture that starts anterior and distal and propagates proximally and posteriorly. It's a very consistent fibular fracture pattern. It's shown here with the yellow line. It's virtually always in this direction. The challenge with Weber B fractures or supination external rotation injuries is understanding whether the medial side is injured or not, which we'll talk a bit more about later. Weber C fractures are a high fibular fracture and are associated with, in this case, pronation external rotation, given the fact that the fracture is more simple and spiraling. This we would consider external rotation rather than pronation abduction. But just remember that both pronation abduction and pronation external rotation will result in these high fibular fractures. Again, the key feature of this injury pattern is disruption of the syndesmosis. And this, again, is because as the talus pushes on the fibula, in order for it to cause the degree of displacement necessary to break the fibula at this level, you can only do that if the syndesmotic ligaments are also disrupted. So we've alluded a lot about instability and how do we define an unstable ankle? Well, the simplest definition, I think, is disruption of two or more bony or ligamentous constraints. So when these are fractures, it's very clear. So in other words, a bimalleolar or trimalleolar fracture will very clearly result in instability. So if the talus subluxates laterally, You'll first break the fibula, and if it continues to subluxate, it can result in a tension failure of the medial malleolus, and that will result in instability. So again, bimalleolar fracture is generally unstable. But it can also be a fracture combined with a ligamentous injury. So for example, as it's shown in this X-ray here, there's been disruption of the talus is translated laterally, there's disruption of the fibula, and also disruption of the deltoid ligament, which fails in tension, because remember, it's that restraint to translation as the tibia moves laterally. If the medial malleolus tears, that's going to result in instability and lateral subluxation of the talus, as shown here, with a widening of the medial clear space that we talked about earlier. Why does that translation matter? Well, it correlates with outcome, and a big part of that is because as the talus shifts laterally, there's dramatic changes in contact stresses on the talus. For just 1 millimeter of shift, there's a 42% decrease in the contact area in the tibial-talar joint. This means much higher risk of post-traumatic arthritis and cartilage wear. Now, one really important point is that static imaging will not always give you the answer about whether an ankle is unstable. And this is particularly true in the Weber B fracture patterns. In these patterns, you'll often have a situation like the one here. You'll get static imaging in the emergency department. You'll see the Weber B fibula fracture, and by all the parameters, this is a stable ankle. The medial clear space is symmetric with the superior clear space, and there's no sign of talar subluxation. So the deltoid ligament appears attacked. But is it really? This is the same patient under stress examination. You can see that under some stress, in other words, if you push the talus laterally, there's marked medial clear space widening and a clear, complete deltoid ligament injury. And this is actually done in this particular example using something called a gravity stress view, where the ankle patient is asked to lie on their side with their foot off the end of the bed, which applies a lateral stress to the ankle just simply due to gravity. And this can reveal this occult instability. There are multiple ways to do this. It's beyond the scope of this talk, but all of these I think are acceptable methods for stressing an ankle. You can manually apply stress either with plain radiography or a fluoroscopy machine if available. You can do gravity stress, which is often the simple and easiest in the emergency department. Or you can do a weight-bearing stress X-ray if you have that capability. The advantage of this is that the physiologic stress, the downside is that many patients can't tolerate weight-bearing after ankle fracture. The syndesmosis can also have occult instability. And here's an example. Now, this patient clearly does not have an occult instability. This is, at this point, grossly unstable. It's an open ankle fracture dislocation. And so this is indicated for surgery. But after fixation of the fibula, are we stable now? We've now addressed the fibula. We know the deltoid ligament is torn from the prior image. But if we fix the fibula, we should be stable, right? Well, not necessarily. In this case, at the end of fixing the fibula, it's important to always re-stress the ankle. And here we find very clearly widening of the tibiofibular clear space in addition to the medial clear space. That means we still have two disruptions. In this case, the deltoid ligament and the syndesmotic ligaments are disrupted, which means we still have an unstable ankle and we still have talar shift. So this can be addressed, in this case, using syndesmotic fixation. So it's very important at the conclusion of a case to test the ankle for stability and apply syndesmotic fixation as needed. This is a relatively simple way of thinking about surgical indications. If you have an ankle that is stable on static x-rays and dynamic, then this can be treated non-operatively. And in fact, these patients can often be treated with early weight bearing in a boot if available. In the second scenario, you have an ankle that is stable on static imaging, but unstable on dynamic imaging, like one of the stress tests that I showed. This is, I think, more of a gray zone and depends on a number of factors. I think some of these patients could be treated with surgery or with casting. I don't think they should be treated with early mobilization in a cast, but certainly casting with delayed mobilization is reasonable for many of these injuries. The decision here ultimately rests with other factors like the patient's age, the degree of instability, and patient preferences. For me, it's often a shared decision and a discussion in the clinic about whether they would prefer the risks of surgery or the risks of non-operative treatment. The degree of instability is wide. Some patients, like the one I previously showed, you get a gravity stress view and there's marked medial clear space widening. Others have only subtle widening of 1 millimeter or 2, and I think that's an important driver of treatment in these situations as well. And then the third scenario is where it's the patient on presentation is unstable on static imaging. These more typically are going to recommend surgery unless there's some medical contraindication to surgery. The patient's very elderly or low demand. Now, interestingly, these patients were assessed in a relatively recent clinical trial published in JAMA. This was a multi-center study in the UK of all unstable ankle fractures. So this is the third scenario where on static imaging, these were all unstable fractures, but in older patients over the age of 60. And these patients, they randomized them to either get surgery with ORIF or close contact casting, which is a well-fitting plaster plus fiberglass cast. Now, notably, this casting was done in the operating room with anesthesia and with fluoroscopy. And what did they find? They actually found no difference at 6 months in terms of on functional outcome surveys. But I think it's important to note about 20% of the patients randomized to non-operative treatment actually converted to surgery. Some converted immediately because they didn't want non-operative treatment, and others converted later due to loss of reduction. Ultimately, when you look a little deeper in their results, non-operative treatment had higher rates of malunion than non-union, not surprisingly, whereas operative treatment had higher rates of infection and required more operative time and more resources. So I think this is an important study just to understand what we can anticipate from conservative treatment. If you're in a setting where surgery is simply not realistic for some patients, I think it's really important to understand that you can achieve good outcomes with this technique. It's worth if you want to learn more about their technique, because there are a lot of important technical nuances to a good cast and a good reduction. They have a very nice videos on YouTube that show the technique of how they apply these close contact casts. So it's worth looking at if you're unfamiliar with the technique. If you are going to do surgery in the cases of instability, then there are different approaches you can take for each of the sources of instability. If the source of instability is a broken fibula that needs to be addressed, then the fixation strategy depends on the pattern. For the most common Weber B supination and external rotation injuries, there are two main approaches that are used. The first is a lag screw with a neutralization plate. This is typically done through a direct lateral approach. And it appears as it's shown in this image here, where a lag screw is applied first, followed by the plate to neutralize the forces across that lag screw. Here's just an example of a fluoroscopy showing the two lag screws getting some compression across the fracture and maintaining the reduction, followed by the plate. And again, note that this plate is placed directly lateral. The screws distally are short cancella screws that are aiming at the ankle joint. The other technique is the called the anti-glide plate, or it's really a form of buttress plating, I would argue. And this goes in through a posterior lateral approach. So it's a similar incision, but shifted just along the posterior border of the fibula typically. And the plate is applied along the posterior lateral aspect of the fibula. This is another example. The advantages of this approach are it's biomechanically in a very favorable position because it's buttressing the apex of the Weber B fracture. So this third screw from the top is the most important screw because it's the one that's actually holding the plate down, and the plate acts like a thumb holding that fibular fracture reduced. The next two screws, the screw 4 and 5 from the top, are interfragmentary screws that can be placed lag by technique if desired. And then the distal screw aims posterior to anterior. And though it all seems like it's only getting one screw instead of the two screws that were shown with lag screw neutralization, if you look on the lateral, you'll see that this screw is much, much longer, and it's actually bicortical. So this is in this particular case is a 30 millimeter screw going from posterior to anterior, so it gets excellent fixation. So the bottom line is this technique results in improved biomechanical stability compared to lag screw with neutralization. It's also more favorable in poor bone quality because the buttress screw, that third from the top, is in much higher quality bone compared to the lag screw that's being placed more distally. Now, why not do this every time? Well, I think it's technically more difficult. The exposure requires, it can be awkward especially as you're getting used to it, to place a very large hip bump to get in position to place this. You'll also notice the twist in the plate, and that posterior lateral contour of the fibula requires twisting the plate quite a bit. Otherwise, the plate can sit off the bone and cause irritation of the peroneal tendons, which is one of the criticisms of this approach. However, in my opinion and experience, which this is my preferred technique, with practice and taking the time to get a good plate contour, this is a very useful technique. The other common fibula pattern is a more comminuted fracture, such as in a pronation abduction type injury. These can be treated with bridge plating, using either direct or indirect reduction techniques. These are often fractures where you might consider using a pre-contour or even locking plate, depending on the bone quality, although it's not required. But if the indirect reduction techniques are used, it's very important to use assess the radiographic parameters that were described, such as the Shenton's line, the dime sign, and talocrural angle to ensure that fibular length has been restored. The medial malleolus, 99% of the time, is a tension failure due to a supination, external rotation, or pronation injury. And these are very simply treated using lag screws, just two screws placed as shown in the image here. If there are concerns about bone qualities, it can be made bicortical as well if long screws are available. In cases of the supination adduction injury that result in a very vertical medial malleolus fracture, then a buttress plate ought to be applied. Again, remember the talus is trying to escape medially in these cases. So by placing the plate medially, you're buttressing against that displacement. And the fibula, in contrast, is failing in tension and can be treated with lag screws if desired. I'm not going to take the time to go in depth on posterior malleolar fractures in this case, except to say that I'm not a big fan of anterior to posterior screws. I think that for the vast majority, a buttress plate using a posterior lateral approach, as shown on the right screen, is preferable. It allows you to both obtain the reduction through your open approach and maintain the reduction using buttress plating much more effectively than anterior to posterior screws. The syndesmosis is a complex topic, and again, beyond the scope of this talk, there are a lot of different controversies in terms of how to obtain the reduction and what type of fixation to use to maintain it, whether to remove it, so on and so forth. I think the most important message is to identify and treat syndesmotic instability. Beware of the Weber C fractures and Weber B fractures. Remember to always test them at the end for instability after fixing the fibula. That's the most important message from this talk. So just to wrap it up, remember the ankle is a highly constrained joint. Understand that conceptual relationship of the malleoli and the ligamentous structures. Remember that if you disrupt two of those structures, whether it's the bone or the ligament, you will have instability, which is the driver of the surgical indications. It's important to know the normal radiographic parameters on both the mortise and lateral views in particular, and understand the classification systems and be able to relate the Weber to the Lauge-Hansen system. Weber A is SAD, Weber B is SER, and Weber C is a pronation injury, and understand what the implications of those classification systems are for the direction that the talus has displaced. And remember to apply the fixation based on the fracture pattern and the mode of failure in that direction of talar displacement. Thank you.